You are listening to Med School Radio, and we are discussing thrombosis and hemostasis. Now we will discuss clinical evaluation of bleeding disorders. A history of mild bleeding symptoms is surprisingly common, including frequent epistaxis, easy bruising, bleeding after tooth extraction, and menorrhagia. On the other hand, excessive bleeding from trivial wounds is more common with serious bleeding disorders. A family history of serious bleeding disorders must be sought. Disorders of platelet function, or von Willebrand's factor, usually manifest as petechial or capillary hemorrhage with easy bruising, mucous membrane bleeding, epistaxis, and excessive menstrual flow. In contrast, hematoma formation in hemarthroses and purpura is more common with larger vessel bleeding, and bleeding from deficiency is one of the coagulation factors. In fact, an inherited coagulopathy is also associated with a history of repeated episodes of bleeding soon after birth and continuing hereafter through childhood and adulthood. Severe thrombocytopenia is often associated with a hematologic malignancy in patients undergoing chemotherapy. Patients with liver disease may also develop multi-factor deficiency states because most of the clotting factors, except von Willebrand's factors, are synthesized by hepatocytes in the liver. Of course, patients on warfarin can develop deficiency of vitamin K dependent factors, i.e. 2, 7, 9, and 10. The most useful tests to begin an evaluation of the cause of a possible bleeding disorder are the platelet count, bleeding time, prothrombin time, or PT, and activated partial thromboplastin time, or APTT. Other more targeted tests are usually ordered by a hematologist and include specific factor and inhibitor assays, fibrinogen, and FSPs. The platelet count is provided by automated instruments, but artifacts may occur because of clumping. Consequently, it is good practice in the case of a low platelet count to estimate the platelet count by inspecting a stained peripheral blood smear. With a normal platelet count, there should be 1 platelet for every 20 blood cells. The bleeding time is performed using a template apparatus and a blood pressure cuff applied to the upper arm inflated to 40 milligrams of mercury. Millimeters of mercury. The template is applied to the skin after cleaning with alcohol, and 2 1 millimeter deep by 10 millimeter long incisions are made. A stopwatch is used to assess time to clotting, and every 30 seconds the blood from each wound is blotted with filter paper without disrupting the wound. The normal bleeding time is in the range of 3 to 7 minutes. Bleeding time requires expert technique, otherwise the results are suspect. A growing number of hematologists are questioning whether or not it still should be performed. Nonetheless, in expert hands, a bleeding time of greater than 18 minutes can detect clinically significant von Willebrand disease or a functional defect of platelet function associated with a normal platelet count. The prothrombin time measures the function of the extrinsic or tissue factor and common pathways. The prothrombin time is also more sensitive to multiple defects that attend vitamin K deficiency or inhibition. In the assay, the technologist adds back to citrated plasma both calcium ion and a commercial or human brain thromboplastin. This tissue factor surrogate provides the stimulus necessary to activate factor 7. The PT or prothrombin time can vary depending on the type of thromboplastin used. The test is used to monitor patients on oral warfarin anticoagulation therapy, and the sensitivity to various coagulation factor deficiencies must be factored in when interpreting a prolonged PT. To standardize different preparations, an International Normalized Ratio, or INR, has been developed. The INR depends on a calibration system that provides an international sensitivity index. Using a formula, the laboratory calculates the INR. In general, a PT 1.5 to 2 times the control value suggests coagulation factors are less than 20% of normal. When the PT exceeds 2 times the control, factor levels have usually declined to less than 10% of normal. The activated partial thromboplastin time, or APTT, measures the intrinsic and common pathways, including factors 12, 11, 7, 10, and 5. In this assay, the technologist adds kaolin as a surface, calcium ions, and a phospholipid to citrated plasma. Depending on the reagents, a normal APTT ranges from 25 to 38 seconds. Considering this wide range, the laboratory must publish its normal reference range. A deficiency of any of the factors measured by the APTT can abnormally in fibrinogen, or the presence of a circulating inhibitor will prolong the APTT. Factor deficiency must be less than 40% of normal to prolong the APTT. This test is abnormal in the presence of heparin and the lupus anticoagulant antiphospholipid antibody. The thrombin time measures the conversion of fibrinogen to fibrin. The test is prolonged in patients with decreased or abnormal fibrinogen and in the presence of elevated FDPs. Consequently, this test is positive in DIC and liver disease. Coagulation laboratories also quantify fibrinogen by various methods. And now let's continue on to discuss platelet disorders. We'll begin with thrombocytopenias. Platelets release vasoconstrictors bound in intracellular granules that help bring about vasoconstriction after injury to a vessel. Platelets aggregate at the site of vessel injury to plug a tear and provide a phospholipid-rich surface for the activation of the coagulation proteins involved in secondary hemostasis. Thus, it is clear that abnormalities in number and function of platelets will be attended by bleeding. As a rule, the skin is the most frequent site of bleeding in a platelet disorder and is manifested by petechiae, which are uncommon in clotting factor disorders. Remember, now we're talking about a platelet disorder. So in a platelet disorder, you're going to see petechiae. And remember that these include bleeding time from the nose, upper and lower GI tracts, and GU tracts, especially heavy menstrual flow. The normal platelet count is 150,000 to 400,000, and low platelet counts, thrombocytopenia, can be caused by decreased production or increased destruction. When the platelet count is between 50,000 and 100,000 per microliter, severe trauma may prolong the time to achieve hemostasis. Remember, the hemostasis is stopping bleeding. When counts are between 20,000 and 50,000 per microliter, bleeding occurs with minor trauma. However, below 20,000 per microliter, spontaneous bleeding may occur, including into the CNS. Decreased production of platelets can occur in aplastic anemia and from damage to the bone marrow from drugs, toxic chemicals, and ionizing radiation. Metastatic cancer may encroach on the marrow, as in leukemia, lymphoma, breast or prostate cancer, with suppression of platelet production. Cobalamin or folate deficiency can adversely affect platelet production because multiple cell divisions are required for their formation. Immune thrombocytopenia appears to involve development of autoantibodies against platelet membrane glycoproteins, binding of immune complexes to platelet Fc receptors, and sometimes the binding of complement to platelets with lysis. Idiopathic thrombocytopenia pura, or ITP, occurs in an acute form in children and a chronic form in adults. ITP is an autoimmune bleeding disorder in which antibodies to a variety of platelet membrane glycoproteins have been identified, including those to GP2B/3A and 1B/9 and 1A/2A. These antibody-coated platelets are destroyed in the spleen. Clinical manifestations include petechiae, ecchymosis, epistaxis, and menorrhagia in women. Childhood ITP usually follows a viral infection and tends to be self-limited. By 4 to 6 weeks, approximately 70% of children have recovered. In adults, ITP tends to be chronic and most patients will require prednisone. The synthetic glucocorticoid acts to block ingestion of antibody-coated platelets by macrophages and to suppress antibody synthesis. It may also stabilize the vessel wall and decrease the tendency to microscopic bleeding. Another therapeutic approach to intravenous gamma globulin or IV is intravenous gamma globulin or IVG, which is believed to block Fc receptors or macrophages. Some patients will require a splenectomy. Immune thrombocytopenia is found in association with systemic lupus erythematosus and with several drugs, including quinine, quinidine, and sulfa compounds. Heparin therapy causes thrombocytopenia in 3 to 5% of individuals. An antibody forms against the complex of heparin and platelet factor IV, a component of the A granules or alpha granules that specifically binds heparin.